Dr. Loy, thank you so much for joining us. I want you to talk, if you can, a little bit about the FDA approval process for emerging diagnostic tests and explain what the approval process was for some of the newer assays compared to the older ones.
Well, I think what we've witnessed is a recent FDA approval process largely focused on companion diagnostics, and then to some extent some other decision to treat versus not to treat methodologies. I think that the value in having a more rigorous and well-defined FDA process will help folks in the planning stages. Many of these folks that are developing these tests largely are growing out of the laboratory industry, and they don't necessarily have the deep pockets. So we certainly don't want to stifle this innovation. There's certainly a huge promise that it's in all of our interest to be able to harvest and get that to market quickly. What we don't want to do, though, is generate a lot of tests that we can't rely on for the long term.
Let's talk about provider acceptance. Has it mattered to a provider that the FDA has reviewed and cleared this test?
Well, I won't answer for all the providers, but as we sit here today, I'm not sure the provider is necessarily in the position to understand what the rigors are of a test that they're ordering today. So for example, if you choose to use a provider of a genetic test and it's the pathologist discretion on who to outsource that to, then they have very little visibility about the quality and the analytic validity nor the methodology of those tests. So we're really reliant on a fairly black box system to be able to generate what we believe is standardized quality.
Does the adoption of new assays such as Prosigna to large testing laboratories provide a new value proposition to payers?
Well, I believe that it really creates some disruption when you've got a single source or largely a small source of those folks that are labs that are providing a test today. So when you begin to have options and choices, now all of a sudden you've got a discussion around price point, accessibility, decentralization, how interpretable the information is, ease of doing business, the ability to generate sufficient turnaround time in order for them to get out in front and not delay therapy. All those become extremely important pieces of the discussion above and beyond just the evidence base.
All right, there was a recent study, which was the TransAttack trial published last year in JCO. And the trial conducted a head-to-head evaluation of Prosigna based on PAM50 and Oncotype DX to predict disease recurrence. Can you share your thoughts, perhaps, on the importance of that study?
Well, I think we're still early. So, and again, in a trial design of that type, where you're going head to head with this, I think folks are still asking and trying to answer the questions of, are we confident enough in the information to be able to tell folks not to be treated? Mm-hmm. And that's a very different conversation for a young person versus an older person.
Sure. But you know, the study found that 26% fewer patients were classified in that intermediate risk category. And in fact, they were reclassified with Prosigna into the high-risk category. So it took a bunch of patients who might not be otherwise treated and put them into a group that might be treated. That's a big chunk, 26%. So how do you expect the more stringent classification to bear on the treatment in the long term?
Well, I think we're still early. And I would say to my, if I were sitting with you here today and you were delivering that information to me, I would want to ask you, how well do you know what you know? And again, if I was coming to the conversation to say, I want to get treated, and you were using this to affirm, I don't think it would change much. But if you were saying to me, I want to use this information to withhold treatment and not live with some regret, then I'm on the other end of the spectrum. So I'm not sure that most folks are using this question to be able to decide to treat. I think they're trying to use it to not treat.
Well, it shrinks the intermediate group.
That's right.
And it expands the, if you will, the treat group.
But I suspect if you're intermediate and you come to this conversation saying, I do want to get chemotherapy, well, this test convinced me to do otherwise, then I would say my decision probably hasn't changed.
So in your view, it's kind of a meatball group, intermediate and high risk. You're probably going to treat both if they want to be treated.
I think, yeah, not knowing versus high risk, and if you're not wanting to live with regret, you're probably going to get treated, would be my guess.